Hi, good evening, and welcome to your favorite medical show, Ask Dr. Saw. Wherever you're joining us from tonight, I know we have a lot of fans out in the diaspora. For those in the US and Canada, good evening to you. I know some people are joining us from the UK. It's about 12 midnight there, so I want to say good night to you there. And of course, our local fans right here in Guyana. Thank you so much for joining us. This, as I said, this was your favorite show. The feedback that we've been receiving from the viewers and people who've been calling us to say that they really do enjoy this show. And we're getting calls already, but we're not ready for calls. We've just started the show. So again, good night to you wherever you're joining us from. Again, the show is called Ask Dr. Saw, and in studio as ever is Dr. Saw. Dr. Saw, good night. How have you been?
Nice, thank you. I've been good. I think my voice is a little bit croaky,
Yeah.
a bit hoarse. I had a function over the weekend, a wedding I attended.
Oh wow.
Usually Indian wedding, 3 days in
You feel
succession.
bad?
No, just late nights, maybe
Yeah,
like
yeah,
to
yeah,
sleep
yeah, yeah,
late
yeah.
nights, Friday, Saturday, Sunday.
Wow.
So
Yeah.
I feel it.
Man, I used to enjoy. I used
Fell
to
down my
enjoy
throat.
those weddings, and I used to be there from Thursday night, Friday, Saturday, Sunday, Monday, and then you want to go back on the second Sunday.
Indeed.
Yeah, it's such a wonderful thing. The culture here in Guyana is an amazing thing. And tonight on show is the right here in Guyana is the Global Cricket Super League, which is the first standalone cricket tournament held here in South America.
Yes, I heard
So
that.
yeah, that's happening. I know, but we have our viewers here tonight, and I want to say good night to you guys who are still here with us. Let me just say good night to Lorraine, Mamzo Mamzo's watching from Canada, Rennie Bipat, and Lorraine, and everybody who is watching us tonight. Thank you for joining us tonight. Tonight we're dealing with a subject and a topic that is very, very important. Is a topic that I myself would have been. I would have gone through a little bit of depression from time to time. So this topic is no stranger to me. I've got questions to ask you from a personal perspective, and that of course we've got the questions from the public that'll be coming in. I see we're going to be getting some live score. Thanks, Harris Delaney, for the live score you're sending us here. And so Doc, tonight we're talking about depression and mental health. And I know this is a big subject because a lot of people that I talk to, they mention that depression takes hold of them, and of course, depression is generalized in some ways, but there are different types of depression. I would understand. For instance, I always would have heard of postpartum depression. Then there's clinical depression. Then there's atypical depression and dysthymia.
Correct.
Those are the ones that I did some research on that. So Shelly Mangru and Savi Sulal, and you guys, thank you so much for joining us tonight. Doc, let's start off this evening's conversation with. Let me. What exactly is depression? Is depression a clinical condition? Is it a psychological? What is it? Depression really?
So I will go on to define it. What is the diagnostic criteria for depression? But I just want to start by saying that mental health generally, when we talk about mental health, I want to destigmatize mental health because often we focus a lot on physical health and we put mental health in the back burner. But I mean, think about it. Our mental state governs everything. So when people say, fine, you've got mental health problems, we all have mental health states in terms of where our mental health is causing us to function on a normal basis. So for instance, if we don't have some degree of stress or anxiety normally, we may not get up in the morning to go to work because we are anxious, we want to reach on time.
Yes.
We're anxious because there's something to do. So there is some motivational aspects of our mental state that we cannot stigmatize that as a disease process. And even so, we want to say that, okay, all of us are different in different ways and we respond differently to stressors or triggers in the environment that can cause us either having an hypersensitive response or a type of maladaptive response. And
Right.
there are various factors to that. So I'll explain that a bit more in detail. But when we talk about depression as a condition, depression means that the predominant symptom of low mood is constant, is always there. Well, there are elements of depression where it's a really fluid thing. It is not, because there are lots of psychiatric conditions or mental health conditions that has got components of depression. But when we talk about clinical depression, significant depression, we're talking about a predominant feeling of sadness.
Right, right.
So let us talk, let us dissect. We're going to dissect feelings.
Right.
Feeling is an emotion. So we're talking about a predominant feeling of sadness, which we have lost pleasure in almost all activities.
Yes, yes.
So
yes.
those two are important criteria to establish. So a predominant feeling of sadness with loss of pleasure in activities, right? However, there are some criteria that the International Classification of Disease, we call it ICD, and there are different bodies like the DSM, Diagnostic and Statistical Manual, where they give you different criteria for depression and clinical depression. So I want Robert to put up a slide for me that I just want to focus a little on this, because when people say, do I have clinical depression that warrants treatment or seeing somebody, I want people to recognize it.
Right,
and it is not about also you recognize it for yourself. I want it for you to recognize it if it exists in other people close to you. Family, friends, because lots of time I don't get a depressed patient all the time necessarily coming to me and say, Doc, I'm depressed. Lots of them do, but also it is the family, the friends, relatives who come and say, I think my husband, my boyfriend, or my wife is depressed, or my mother or father. And then, you get them to then you do an assessment. So we say there are two salient components got to be present. So you have predominant feeling of low mood, so sadness, loss of pleasure in almost all activities. Now, this list that I've got here, I want you to look at it. They say if you have 5 of this,
yes,
you have significant clinical depression. So 5 of this. Now, once it starts then affect your functioning, you get significant weight change or appetite disturbance. So people who get depressed, it starts to affect them in some ways. They may eat too much or they eat less. You have sleep disturbances. You may sleep too much, you don't want to get out of bed, or you don't sleep at all. You insomnia or hypersomnia, they call it, right? You have psychomotor agitation or retardation. That is, you're fidgeting, you are hyperactive.
right.
So, you're always that, or you're sluggish. You're really slow. Your speech is slow. Your movements are slow. So you can have a component of that. You're generally tired, fatigue, loss of energy. There's a feeling of worthlessness. You don't feel valued.
Absolutely, yes.
You feel as if you're not important.
That's right, yeah.
Nothing you do or say matters. And that is why when we talk about, we will come on to suicide after depression, to say that those are key elements to it. You don't feel value. You feel if I'm not around, nobody will miss me.
Yeah.
And also you can't focus. You have poor concentration. It's okay, Robert, we can switch over now. And the important one is also to establish if there are suicidal ideations or suicidal thoughts.
Absolutely.
It would be, you would always, if you're assessing someone for depression, please, I beg of you, anyone, friends, family, if you're assessing them and trying to establish, or, going through all of that, you should and lots of time it's a little bit of a difficult subject to talk on.
Yes, yeah.
You can't.
It is very difficult.
Yeah, for you to broach that. So I can't come and tell a patient right off the bat, do you feel like killing yourself? It would sound a little bit weird.
Yeah.
So
as if you're going to the extreme right away.
Absolutely, but it is important to ask the question, but you may do it in a subtle way.
Yes.
So you can have you ever had thoughts of self-harm? Have you, and then try to tease it in. But that is an important element, because we find that suicidal is very high in depressive patients. So it will be, you should not miss that aspect of it. Now, so if you have 5 of those, and with 2 being predominant feeling of sadness and loss of pleasure in activities, and then the others, so then it can affect, all your sleep and your anything. We would say you have clinical depression, then we go on to say, fine, these are the options. What we would look for, well, they're difficult in terms of establishing causes, right? There are risk factors where people are more prone to some people are more prone to depression because of their circumstances. So, but the theory behind depression, when we look at what is the cause, we call it the etiology or the cause of depression as such, no one knows. And in as much as so much science and so much of what would say, there's so much of research being done, we are still deluded in a way where we can't pinpoint exact cause to say, hey, this is a cause. Now, there is a theory where there's so I just want to highlight that there are the elements of that depression is multifactorial, and we say there is a neurobiological phenomena. So there are chemicals in the brain, and so that is your hormones and neurotransmitter in the brain, so neurobiological. There's an environmental factor. So your experiences, your environment that you're living in, and your experiences over the years, and then there's a strong genetic component in certain types of depression, and even anxiety disorder. There's so much of genes. They have actually identified genes that make you more predisposed to depression and mental health issues and that spectrum of disease condition. So we can't point fingers to say, right, there is one cause, not because you have lost your job, that makes you depressed. There are hundreds of people who lose a job and they still carry on and they're not clinically depressed. So then we look for other components. And there was always this theory that there is a mismatch between your receptors and your chemical in the brain. So, chemical attach receptors and they create this whole cycle of, physiology, how the brain works. And when there's that mismatch of chemical and receptors, you get depressed. But if it was as simplistic as that, then we would expect that everyone we gave antidepressants to, that is the chemical, to rebalance things, we would expect them to respond. But the answer is they all don't respond. So there are some people who don't respond to normal medication. And when we come to the treatment, I'll go through that. There are many, many ways of how we can manage depression. So this is looking at it in a pathophysiology way, meaning that is a causation way of the chemicals in our body and environment. So we know that there are multitude of factors. And then, of course, you have, in the old days, they used to put depression as endogenous and exogenous, meaning if you have depression because you've lost your job, you're separated, you have financial difficulties. And yes, we all have mood disorder. So depression is a type of mood disorder. And we have mood disorders from all of those things. If we don't have money, we are a bit sad. So when we talk about those criteria that I've put up there, they say if you want to make an assessment to diagnose it, you have to have that for 2 weeks, most days for 2 weeks. So if you were to go through that and you tick box, so there are some screening tool we use in practice where we tell patients, can you tell us, we give a score to each point, and then we assess if they're clinically depressed. And we do that routinely. I do that for patients. I mentioned the last time, diabetics, heart disease patients. We do that yearly. We give them a questionnaire and they will tick that, and then we record it in their notes. And that is part of the holistic management of chronic conditions, because anything that makes us ill can get us depressed.
Someone in the comment earlier said, when you put up the slide, someone said that sadly they take off all they
take all the boxes,
all the
points.
So this person here is
so that is indeed, I would say to this person, yes, from the looks of things there, if that is the situation, I would beg of you to get in touch with a doctor. The first port of call usually is your primary care physician, I would imagine. Of course, they're also, and they can direct you into what local services are available, if that's someone abroad or locally also. we have, I mean, today I just before coming on to the show, I had a chat with our, I call up the Ministry of Health just to have a chat with one of the doctors in the mental health department to have an overview of what we have here. And we have made lots of strides in mental health. We have created awareness programs so people are more aware of mental health issues. And I think we have now decentralized, from what I gather from the doctor I spoke to today, we have decentralized mental health in Guyana, whereby it is now accessible in most of the regions. They have different ways of whereby you can be self-referred or you can be referred by another doctor, but they have systems in place. And of course, the intention is to make it accessible across the country and more widely accessible. But I suppose there are factors like everywhere else, there are factors why we can't provide, mental health services as we would like it to be. And this happened in the best of places, to be honest. I mean, we are always deficient on mental health services, how we provide it, internationally, I would say.
The thing is with depression, and I'm happy, I'm really happy that we're having this topic, dealing with this topic tonight, because depression, and I'll tell you this from a personal experience, that depression, when you're going through that bout of depression, you don't even want to tell anybody you're going through depression. You want to stay at home, you want to just sleep, as you rightly said, all these things, but you don't, for some reason or the other, people want to talk about depression when they've snapped out of it.
Yeah,
a lot of times,
as if it's a historical thing.
That's right. You know what? I went through depression.
Correct.
But while you are going through that period of depression, and for whatever reason, as you know, there's several factors that will bring on this condition. If I may call that.
Yeah.
But what should we? And somebody said isolation, right? Absolutely. Isolation is one of the things. You just want to stay away from the world,
Absolutely.
Yeah.
And isolation also is a medical condition, is a condition that we have, social isolation, where we've recognized that as a cause of depression. So you want to feel isolated, where you want to lock yourself from society, as one of the points that I've put up there.
Yes.
You don't feel like going out, you don't feel like doing activities. You have that as part of the criteria, but also isolation, as in loneliness.
Yes.
Is a big cause of depression. If we look at loneliness, and if you look at, thank God, in Ghana we have lots of extended family. When we look at depression in the Western world, as loneliness as a cause of depression in the Western world, that's a big deal. I have lots of patients on my, in my surgery who, they live alone, and in the culturally, in Europe, you have lots of people, the kids move on and they end up living alone. And that by itself is loneliness. And loneliness, you may see people coming in, but nobody playing an active role in, okay, how you doing? How you feeling today, Akash?
Right.
Nobody interested to know what are your hopes and aspirations. What would you have that meaningful conversation. So we may see somebody and say, right, the nurse coming in 2 days a week, they're visiting my mom, they're coming in, they're visiting, whatever. But that person can still suffer from loneliness. But coming back to the point of isolation, that you want to isolate yourself and you don't want to talk about it, it's because there is this stigma attached to depression, and none of us want to, we don't want to, we want our life. How do we portray our life? We portray our life to people to see us that, okay, we're doing well, everything is good. We're happy, we are rich, we're, driving a fancy car, we're living in a fancy house. Nobody wants to say that, okay, this is the reality of my life.
Yeah. We want to present that
right.
person to the world.
Unfortunately, yes, the world makes judgment on us.
Yes, exactly.
And it has implications in that sense.
Indeed.
So we have to face up to that reality.
Yeah.
And, it is a difficult one. And I would say to people, don't get ourselves in a state. We always want to be truthful as much as we can, because I feel that life is, you're happier when you're truthful. in terms of even when you're suffering from conditions, you don't need to advertise it to John public, but at the same time, there would be people you're close to, you can talk about it. And also, once you take away that burden where the world is judging me, I mean, to be honest, half of the time, the things we are thinking in our head, they're not actually true.
True.
Nobody cares
Absolutely.
if you have
Absolutely.
4 meals a day or 2 meals a day.
Yes, yes, that's right. That's right. Yeah.
Nobody would be
Yeah,
bothered
yeah,
so
yeah.
much so.
But
I mean,
we
if
think
we
that
we are
if
being
the world
judged.
knows this, what are they going to think about? What are they going to think about? What are they going to think about? We put
Absolutely, correct.
undue
Pressure on
stress.
ourselves
Yes.
and undue stress. So when you look at how our mind body system, how our mind and body work, the mind body theory, it's very complicated. It's well studied, but actually I don't think there's any clear clarity in it.
Yeah.
I mean, what is the mind? So you have the mind as a concept,
Yes.
and how is that dictated? How that control our thoughts? So we think something, our feelings, we feel something. I could think something bad, and I feel bad, and then our behavior.
Yeah.
So when you talk about, so that's why there's a component of psychotherapy. When we talk about cognitive behavioral therapy, we try to zoom in on those domains.
Yeah.
So you think, so you want to change that concept, that thinking, feeling, behavior. So if we could look at that, look at it in that way, that's therapeutic, and that's what the psychotherapist is going to work on. So I think that part of it we should empower ourselves to have positive thinking, positive feeling, and then our outward behavior will be positive.
Yeah.
And so I think those are the components. And then we talk about anxiety as a type of disorder as well. I mean, anxiety is needed, as I say, for most of us to function to some degree. When it becomes a problem, if it is overly heightened, and we have this dreadful fear of, or we have an exaggerated, thinking of the dangers, of potential dangers, and that is what presents as anxiety.
Yeah.
Now, go ahead. Sorry, you're going to say the
because
spectrum.
right. No, I was going to ask. You're talking about you when you feel something, the reaction of the body reacts. What is it? I hope I'm not jumping to something, but I just want to ask what is the if you serotonin, dopamine.
Yes. Right. So those are the components: noradrenaline, norepinephrine, serotonin, dopamine, GABA. These are all neurotransmitters in the brain.
Right.
And they control excitation and they control inhibition in a balanced way, right? Now, there are different parts of our body, our brain, that they control emotions. And when these neurotransmitters are activated or they are regulated, so when we talk about what are the neurochemical problems in the theory of depression, there's a dysregulation of those neurotransmitters. And that is why the drugs that are used for depression are drugs that target those chemicals. So we have something called the SSRI. So coming to the management, so let us just talk a little about that.
Yes,
how do we manage that? And then, we can touch on other subjects. So, okay, fine. So we've established someone is depressed. I always start with non-pharmacologic management. So let us look at
exactly.
I always try to
because they're pharmacological.
So pharmacologic is your tablets and your medicines and stuff like that. So you want to talk about non-pharmacologic management. So the non-pharmacologic management, high on the agenda will be psychotherapy. So psychotherapy is a talking therapy.
Yeah.
So I touch a little bit on that thought process, that feeling process, and that behavior process. And cognitive behavioral therapy is a well-established type of psychotherapy that is proven to help. And it is a way of a measured way, focused way, an individualized way. And you have different types of CBT. It's called, CBT, where you target. I may change the way you feel about something by giving you other dimensions to it. Put it in a different way for you to, why don't you think of this? Every time you think of this problem, you start thinking negatively.
Yes, that's right. Yeah.
I'm going to show you some positives in it. Let us now start, every time this come to mind and you get anxious or you feel depressed, let us look at some thought processes that can make you think differently or feel differently. And then let us look at some of the behaviors. What change in behavior can you adopt to change that feeling? So those are big components. I'm not an expert as a psychotherapist.
Right.
So when I get my patients, I would say, you're right, these are the options. So I would tell patients we have non-pharmacologic, which is psychotherapy as the main one. But of course, there are different aspects, other things you can do. Exercise therapy is well established.
Yeah, yeah.
And that is why when we talk about, there are lots of mindfulness, mind-body dualism, how we talk about the mind as a separate entity from the body, holism as in a holistic way of looking at the mind and body connected.
Health and wellness in a broad perspective.
So those are all, the whole psychological aspect of things. And then initially I would tell patients generally when I do, just a ballpark way of how I would. So if I have a patient with significant clinical depression, I would go through the options with them because in my practice, I try to engage patients. They make the decision how we proceed. Because there's no point I give you a medication and you don't take it and you just accept it, but you're not going to be convinced that it's needed. Because there are lots of, there are lots of fear in medication as well. Lots of people want to know, do I get hooked on the medication? Can I stop the medication? Things like that. So we'll come to that in a minute. So after that, you have the non-pharmacologic psychotherapy, then you have pharmacologic means. And the pharmacologic means are your medication now. And there are different classes of drug. You have the SSRI, you have tricyclic antidepressants, they have MAO. These are all different names, the chemical names. SNRI. So they're all, the names that I mentioned there has to do with the chemical, how they work in the body. Now, so you can do psychotherapy, pharmacology, or you could do both psychotherapy and pharmacology. That is drugs and psychotherapy. So patients have that option. Okay, let us choose one, or let us choose them both, or that's generally how it works. And then there are different. If patients don't respond to that, you have your first line therapy, which is your first line of antidepressants. If that doesn't work, you go to second line antidepressants, and they are electroconvulsive therapy, the shock therapy. When you see these movies, they show you people with depression, they used to shock them. So they have brain stimulation therapy, lots of therapy. Psychiatrists will go through that. If a patient reaches that stage where fine, none of my primary drugs that I will be using as the initial treatment, if they don't work, then I will go on. If it doesn't work and none of those drugs work, then I'll go on to refer to a psychiatrist to look at other interventions. Having said that, there are lots of depression. Just to understand a little bit more, depression is not as simple as, you're depressed or not depressed. There are periods of people going through periods of depression. They're better. Like, you talk about cyclothymia and dysthymia and atypical conditions.
Right.
So your dysthymia is your patient who have got chronic depression, and it's over 2 years. These are patients with chronic depression, and then you have depression that also part of other conditions like bipolar. So your bipolar patients, they have periods of depression and periods of manic type of behavior and depressive period. So your cyclothymia patient have hypomania with depressive, low mood depression. So there are loads of combination of it. So I can't say to someone that, okay, depression is all by itself. It overlaps with lots of things. And then you have depressive psychosis. So it's a really, because complex.
Somebody just asked us a question that is related to that. But before I go to the question, let me say this: that there's a general thought amongst out there in society that, look, if I only go on antidepressant one time, that's it, I hook for life.
God. So that is
right?
not true.
But you've heard, you know.
I heard that. And
Yes.
people say that all the time. Yeah.
Yeah, that once you go on antidepressant, that's it. You're hooked for life, and you've got to stay on it all the time, because without it, the moment you come off it, a day passes and you don't have it in your body, you're basically addicted to this. So, break down this
Okay,
myth.
so let me break that down.
Yeah.
So I said to you that the medication that are used, the medication that are used, they work on a chemical in the brain, right? So we're trying to reset those chemicals. Now, it takes a while. So the first thing is that you can't go to the doctor today, get a medication, and tomorrow you feel better. It's not a medication going to do that.
Right.
It takes a while for the medication to influence that change, to create that change in the chemicals in your body, right? So it will take a while. So I would say to patients, once I have patients who have established diagnosis and we've gone through all the bits and we're going to start a medication, we'll tell them it will take a couple of weeks, maybe a little bit longer, for the effects of the medication to really kick in. The second thing to understand is that sometimes the medication can make you feel worse in the beginning, because some of the SSRI antidepressant medication, they can make you feel a little bit more agitated in the beginning.
That's one of the side effects?
Yes. So that's how it works. And what I tend to do, sometimes I give a short-acting anxiolytic tablet, anxiety tablet, like your normal Valium, low dose of that, or lorazepam, one of those low-dose drug, just to calm things down for the first couple of weeks while you're starting your antidepressant. So that's something that we have to make patient aware of. In children especially, there were some studies shown in adolescents where when you start them with antidepressant, they can have suicidal thoughts as well. So you have to understand some of the side effects of the drug and how to counsel patient how to use it. Now, because the drug changes the chemical processes in the brain in terms of rebalancing it, not that it's dangerous, when you're going to stop the drug, you have to wean yourself off of it. And that's what the confusion lies. It is not that I'm addicted to this drug that for the rest of my life I can't do without it. It's just that you should not be an antidepressant and stop it abruptly. And normally they are tapering those. Tapering is a tapered way of where you reduce the dosage gradually over a period of 4 to 6 weeks. So that's how you come off of antidepressant. And I would say to patients as well, I've seen this, and this is something I said I was going to talk about in other areas as well to highlight. When patients are given medication, they take it today, they stop it tomorrow, they take it again the next day. And I think that is not a good way.
Not sticking to the regimen.
Not sticking to the regimen. And I've seen this, and I mean, unfortunately, I saw a patient last week who has got blood pressure for a couple of years, and now she came in with kidney failure. And on further interrogation, I tried to, get some clarity on what's going on. I realized that she wasn't taking her medication.
Oh, wow.
As one of the contributing factors.
Yes.
But there are many other things that went wrong in that case. But the point is, I would really urge patients and say this to everyone. If you're given medication and you're diagnosed with a condition, please clarify with the doctor, should I be taking this tablet every day? Can I miss a day? Can I come back and take it the next day? And antidepressant and drugs generally in the psychiatry world, we want patients to take it every day. There are some drugs that you can use as and when, like your diazepam I told you about.
Right.
And when.
Yes.
And like if patients come and they need painkiller, as and when. You have migraines. You can use as and when drug when you have an attack. You have asthma, you use the blue inhaler as and when. There are drugs you can use permanently, as in long term, every day, as a preventer. You can have drug preventer for migraine, preventer of asthma, but there are drugs you have to use every day. And unfortunately, this is one in psychiatry. We would always want patients to use the drug every day.
Yeah. I mean, this as I said, this topic and the subject is it's wide. It's a very broad topic, but physical ailments can also, the lack of the lack of ability. Let's take we dealt with erectile dysfunction last week.
Yes.
ED can lead to depression because and there are several other factors. For instance, you're not being able to you're not being able to do the things that you were able to
Perform
do before.
optimally.
You're not able to walk. You used to go walk 3 miles, 3 miles a day. Now because of some illness or some or arthritis, you can't do these things. So the physical condition would lead to these things here. And would you recommend then that those physical conditions be addressed? Because it can.
Absolutely. So when we look at, okay, what causes depression, we don't know, but we know there are environmental factors, there are biological factors, there are all of these things involved. So if I'm starting negatively about something all the time, or I am my physical body can't deliver what I am hoping for, and also when our expectation and the fulfillment, when that gap widen as to the reality and the expectations,
yes.
It creates more disharmony and more sadness.
Yeah.
So if I'm sad about something, I can't run a mile, I get, I may get depressed. So it is true that physical health is very important, as it can contribute to depression. And that's why physical health, heart disease. Now coming to, we talk about erectile dysfunction. Erectile dysfunction can cause relationship issue. That by itself can be a big cause for depression. So it is important that, yes, it is very, it is something that we have to look holistically at.
Yeah, and again, as I said, sometimes we forget to take care of the physical aspects of our lives, and that leads down these dangerous roads that we go down.
Yeah, I mean, we know lots of studies have been done on exercise and how it helps mental health.
Yeah.
And there's endless data to tell us. We prescribe, as a matter of fact, in the UK, there's a exercise prescription for depression.
Wow.
A patient would come to me and I will make a prescription for them to join the gym, and they don't pay.
Okay.
For a period. So they go, they get an assessment, they have let's say a 12-week course of exercise therapy.
Yeah.
And they would see a physiotherapist who will go through a bit of the health, but that is one of the things we would prescribe, exercise for depression.
Emma raising something very good here. She says that we take care of ourselves and we take care of others and forget to take care of ourselves. Yeah,
important.
And I think that is very, very important, because if you don't take care of yourself, ain't nobody gonna take care of you for you.
No, absolutely. I mean, it is important. I mean, it is always when you're in an airplane and they say if the oxygen, there's short of oxygen, you should put your mask on before you put someone else.
Oh, yes,
because if you
they say that, because that's right. How can you take care of them if you
can't take care? And I think it is important. And this is a valid point, to be honest, because ever so often we get consumed. So I see patients all the time come in and say, well, I'm busy, I've got young kids, and I'm working around the clock. I don't get time to come and see the doctor. I don't get time to have a health check. I say, what you're doing actually is an injustice to your children.
Yeah.
It is important for you to provide food on the table and to provide a financial well-being for them. But at the same time, if you become ill, you'll do them more harm than good. So it is critical that you look after yourself. Because if I'm not healthy, my child is going to worry. Absolutely. That is not healthy.
Absolutely.
That is a stress on that child by itself. I may not be able to work then. I may not be able to provide for the family. So these are all important aspects of wellness, general mental health, things, and health in general. I mean, you are a guy big on alternative therapy.
Yeah.
So maybe you can share some of those.
Yeah, actually, I bought a book and I'm reading that book. It's called Dianetics. You've heard of it, L. Ron Hubbard. And these are a lot about psychosomatic illnesses and how we bring on these illnesses on ourselves. But on this subject, and somebody said this is very great. I always worried about it because so many youths are committing suicide, and it is very sad. It's something to talk about. Now, the problem though here is that a lot of times, we all know that nobody, when you're going through depression, you don't want to talk to anybody or anything like that. But a lot of times, Dr. Saw, people don't want to talk because they don't believe that there is going to be confidentiality. And
I'm glad you raised that.
right, confidentiality, and the people that they're going to be talking to, they say, I don't know if I'm going to tell them, because a lot of times what brings on the depression is
Something
personal and taboo sometimes, right?
Yeah.
It's taboo, it's personal, it has to do with lifestyles and all of that, and society doesn't accept these things. So my thing is that when you would have spoken today to the personnel at
doctor,
yes, did they establish whether there are places and confidential persons
I would
that
say
they can call and talk to?
Yeah. So in the medical profession,
Yeah.
We are duty bound to maintain confidentiality. That is ingrained in the profession. Now, so I wouldn't think that is something, you can't overemphasize that.
Yeah.
If you tell me something, I can't tell it back to your wife even, or your child, or without seeking your permission.
Yes.
And we are bound by those. There are laws, there are ethical. I mean, in the UK, it's a law on that. If I were to break confidentiality, I'll be reported to the medical council, and I'm answerable to them, and I can lose my license for that.
Yes.
They view that very, very serious. Now, unfortunately, in different cultures and different society, it is not, it's not practiced so much in such a strict way. And for, there are many reasons. It's difficult. I don't understand the dynamics at this point in time to understand enough to say if that is not happening, why it's not happening. So I'd probably have to go and look at. So what we have, a system that is foolproof, would ensure that history taken, notes taken, it's also confidential. So I don't know, you wouldn't have access to what I've written in the patient notes unless you have that level of clearance. So I think eventually we'll come to that, but we have to understand our limitations in a country that is now evolving in that way, where we're going to get electronic records. And so if I write something, this patient reported X, Y, and Z, it wouldn't fall in the wrong hands. So these are all safeguarding things we need to practice. Now, so I haven't established that in my conversation today, but I know that it is embedded in our training that confidentiality is utmost, should be protected and respected. So that goes without saying. What we need as policymakers and people who monitor the system is to give that reassurance and put safeguards in place.
Absolutely.
That if that is broken, that people are held accountable.
Yeah. Because a lot of times I know that people, they want to talk to somebody. You know that is the only way. You know it within you that, hey, this thing is like in Guyanese, this thing will boil up inside of you, right?
Correct. Yeah.
It's boiling up inside of you, and you know that you have to speak to somebody. You want to talk to somebody, but at the same time you're asking yourself, man, but what if I go and talk to this lady now, and she gonna tell somebody, and they reach back to this person, and reach back to that person. So Renee's saying here, apart from confidentiality, depressed people will deny that they have a problem.
Yes, true. And that's why we try to engage family members. We try to engage, as many people as possible. And when it comes to therapy, sometimes we do group therapy. We, family therapy. Those are all important, how we go about managing it. And yeah, most times it is true. I mean, mental health generally, someone else would rely from, cooperating the history or having someone else report what is going on in that person's life.
Yeah. And, but I usually tell people, look, you got to talk to somebody. You got to talk to somebody. Just having a conversation with someone can change things drastically or dramatically, because you're in a position where you feel like the walls are caving in on you.
I suppose we can look at establishing some in the interim while our confidentiality aspect is being looked at in a very foolproof way. We can look at anonymously talking to people, because sometimes we just want to get that off our chests without those specifics. But not to say, I have patients will come back and give me a feedback to say, fine, I'm having some psychotherapy and I haven't connected with my counselor as well as I should. So sometimes you want also that connection with that person. So they need to know you a little bit more in detail, understand your life circumstances. And that is an important aspect of it. And then when you confide in that person, then you release. You let go of some of those things that you have, penting up, and it is important. So I think we it's important we get that. I mean, not to say that family members can't be on the lookout in terms of like if you have a friend that you confide in and genuinely confide in, where you know that this level of information not going to be exposed. And you could do it. And all of us should be looking out for each other. And I think it is important to ask people how they feel, how the day go in. And you can sense something with co-workers sometimes. You sense when something is wrong.
And again, I'll say this again. Some of the major issues surrounding those things is, again, leads to confidentiality. Mama, if I tell this girl we're going out with me, she gonna tell the girl, then Denise gonna tell the and then it's again, as you rightly said, we don't even know if that's gonna be the case. But we put it in our heads that no, I don't want to tell this person because the person might tell that person. But genuinely, that person that you want to tell may really want to help you.
Correct. I mean, I think if you have so much of severe clinical depression to that extent in the criteria that I put up, right? You have, it's difficult sometimes. You get clouded judgment sometimes, and you can't rationalize clearly. But that is enough to say that, okay, if I reach that stage where I have suicidal thoughts, it is inherent in us to want to live. It's when something gone bad that we want to end our life, that should take precedence over everything. And say, fine, I prefer, to talk to somebody and distrust the system than not to talk at all and end up dead.
Look, survival is one of the basic concepts of any organism.
Yeah, absolutely.
Any organism, and you want to survive. You'll do what it takes to survive. So it leads down to a very dangerous road when somebody has to go. There's like Gita saying, I knew someone who used to smile and laugh all the time, and when that person committed suicide, his notes that he left were shocking to learn about the dark world that he was living in.
Yeah, no, indeed. I mean, yes, that's why sometimes people, you want to broach a subject because I tell you what, even, and it was really, I've seen a difference like pre-COVID and post-COVID, right? Patients, when I look at patients who come to talk about depression and anxiety disorder and, lots of other issues, they will come in, and even relationship issues, they'll come into the surgery to tell me something that is really trivial.
Yes.
The reason for booking an appointment would be, well, doc, I'm getting a pain in my hand. And then we will end up chatting. They will then, you'll see that something else is not right. And then they will come up, then they will come forward and reveal a little bit more about what is actually happening. And they may go through a bad patch at work, relationship issues, financial issue. And, and that is why that physical contact during pre-COVID, where we used to have with every patient, you have that one-to-one consultation. And post-COVID, or even during the COVID time, we start doing telephone consultation, which is sort of, it got a place. I'm not saying that it doesn't. But, you need to give patient that option to say, yes, it's good to see me. And there are times when we can have a chat as well on the phone. But that initial consultation where people open up to you is that physical connection that they see you, they talk freely. You're on the phone, you don't have that personal, unless they know you and they know who you're talking to. But if I don't know anybody for the first time I'm talking to someone, maybe you would not get so much information. So there are strategies we can use and systems can be designed along that way to look at those things.
Doc, I want you to touch a little bit on postpartum depression.
Oh yes, right. So that's a big thing, and it is very heartbreaking. Sometimes we have
Oh
seen
my God, yes.
postpartum depression and psychosis. So there are three aspects to postpartum mental health that we are aware of. I mean, as a generalist, I suppose the psychiatrists would have a lot more, but in my line of work, there are three things I tend to look out for in postpartum mental health. So one, we have something called postpartum blues. So postpartum blues would be this mother between the first week, sort of, so between 3 to 6 day, between the third and the sixth day, they would have this low mood and this sadness, and they have thoughts of, okay, am I good enough for my child? Would I manage to take care of this child? And they have that period of sadness, and that can last some hours to days, but it is short-lived. And of course, we encourage that we find that in certain types of patients who don't have the support, you tend to have extended support. So you have spouse support, you would have extended family support. There are also patients who may have pre-existing mental health issues, right? So those are things to note when we see patients with depression or issues during postpartum period. Remember, having a baby, you haven't slept for 2-3 days probably during labor. The baby, you don't know if what's going on. You see a child, they're so fragile. You don't know if you're doing any harm or you're doing good to this child. Just handling the child may be a little bit different. So these are all aspects to it. So that's postpartum blues. So usually that's not just psychotherapy will work with that and a bit of support, right? So supportive therapy. Then you have postpartum depression. And usually postpartum depression will start really around the third month, and it can go on for months, usually in the first year of delivery. And that is clinical significant depression. And again, they would have all these criteria that we talk about depression.
Right.
And, we tend to, again, the high-risk patients would be that patient who have got no support, who probably have mental health issues previously, or a family history of mental health issues. We have to look into all of that. And there is medication, so we use antidepressant drugs. So, however, we always, because of breastfeeding and all of that, we would always go for psychotherapy as a first intervention and supportive therapy, and then, of course, medication. But there is a place for medication. So, without a doubt. So let us don't, clarify. And then you have postpartum psychosis. So psychosis, let me define.
Yes.
So when we talk about mental health issues, we talk about normal stress, we talk about anxiety, we talk about depression, and then we talk about psychosis. And that is where, lots of time, that's where the psychiatrist will come into play. So psychosis is when you lose touch with reality. So what is manifested by hallucinations, delusions, and thought disorder. So if I were to just define psychosis,
Yes.
is loss of touch with reality manifested by hallucinations. So hallucinations are, you could be auditory, it could be visual.
Yeah.
So you're seeing things, you're hearing things.
Tactile.
You're feeling things.
Yeah.
You have that. You're delusional. So you have a false belief. Oh, my neighbor is looking at me all day. Somebody is following me. So you have these thought process, these delusional beliefs, right? And then you have the thought disorder. You're hearing voices, you can hear things. Thought insertion. Somebody's telling me to go on a rampage. Or somebody's telling me something to do. They have thought insertion and, all these things. So these are the dimensions of psychology. And that is when, more or less for a layman, they would say, okay, this person is mad. Right? That's your definition.
Insanity.
So, insanity. So when we talk about people who, they're out of touch and they behave erratic or whatever, and you don't have to necessarily behave erratic, but you have all these things pending up in your head. So, and there are different medications for that. There are antipsychotics, which, we know again, it follows the same pattern of genetic factors, neurochemical factors, neurobiological factors, and environmental factors. And of course, it can get family predisposition. It runs in family, some sort of psychosis. So you would have schizophrenia, like your most common one that people knows about. You can also have depression that can lead to psychosis. You have depressive psychosis. So when I say to you that it's a spectrum disorder where the spectrum runs, you can start with just your normal stress that then give rise to anxiety, then it give rise to depression, and then that depression give rise to psychosis. And then you have, depending on, the different signs and symptoms and other components, they put them in categories. You can have a bipolar condition where they have different types of bipolar. You can have hypomania or manic with depression. So you're excited one moment and you're depressed one moment. Then you have psychosis, the other bipolar. You have psychosis element to it with depression element in it. So these are all different spectrum of of mental health issues that we have to be aware of and address.
Time is so running out on us tonight. The conversation is, I meant really, not to say that I enjoy this conversation, but it's necessary. Very, very necessary. But before, there's a question that's here. Someone asked about, good night, could you ask doctor about misophonia disease, sensitivity to sound?
Right. I mean, I off my head, I can't tell you much about that. But there are people with heightened sensitivity. So even in normal psychiatric conditions, sensitivity in different form, there's tactile, auditory, visual, you can have heightened. So when we talk about, I'm just giving that as in terms of sound sensitivity. And when we talk about post-traumatic stress disorder, we have a heightened fear, and all those sensitivities can be accelerated or enhanced. So you can have that. But a condition in isolation, I can't give details. I'm not a psychiatrist that I know all the ins and outs of each condition, but I can have a look at it for the next topic and have a talk on that.
Yeah.
But in the way our body process information, and that's why when we talk about one of the strategies we use, and I encourage patients to do mindfulness. You heard of mindfulness?
Yes. Mindfulness.
So, yeah, you probably.
So yeah. And I like that there's so much. I mean, this is my line, and this is where I want to go. But a lot of times we tend to, like in the mornings where I'm living on the West Bank, I've started something different I'm doing in the mornings now. I leave my phone aside and all that. I have my coffee and I come out outside, and there are the birds that come out there and start chirping in the mornings.
Yes, yeah.
And I find that meditative state that I'm in, because all of them concentrating on those birds and the sound and so on, it puts you in a good mood. It puts you in a mood to actually propel you through the day. And a lot of times, we forget to take, as the person said earlier, we forget to take care of ourselves in whatever way possible. And we believe that just going about life, going to work, coming home, cook, eat, sleep, going through the basic things in life is what's going to get us through, not realizing that we need to practice mindfulness and needs to practice taking care of ourselves.
Absolutely. And just for the viewers to understand mindfulness, so you want to focus on the moment.
Yeah.
On that moment,
That's
you
right,
want to dissect your feelings, your thoughts, your feelings.
Yeah.
You want to dissect the environment you're in.
Yes.
So you're focusing on the present moment in time. Now, there are different aspects to mindfulness. Sometimes you concentrate on your breathing, you're aware of your tactile stimulus around you as well.
Yeah.
Your body, where is your body position in relation to space and time?
So you do meditation.
And you do meditation. So you're always conscious of that. And there are, people start and say, fine, where's my feet? Where's my leg? What the environment is like? Am I smelling something? So you focus on those aspects. And they send chemicals in our body. There's a new science not new, but it's been wrong in terms of how these things can invoke good chemicals in our body and help to fight diseases as well. You have what is this called? It's a psychoneuroimmunology. Have you heard of that?
Never.
So it's a field where that lots of research is being done in psychoneuroimmunology. So psychotherapy controls your the chemicals in your brain, and it affects your immune system. And that's a big concept.
Yeah.
So when we talk about misophonia as sensitivity to sound, you can put that in perspective where that heightened awareness has implications physically. So it can affect your physiology of your body, and it can affect your psychology, the way you think and the way you interpret those signals.
We're out of time, but what I want to say quickly is that I've seen this being presented a lot of times, heightened awareness to specific colors, sound, and so on, especially in with kids who are autistic. It's that heightened awareness.
Yes, actually, that misophonia is common as in autistic disorder children. Spectrum disorder.
Like I saw, there's this one kid who he just doesn't like yellow.
Of course.
And then certain songs like this, like the sound of a flute or so on.
Correct.
It because of the resonance.
Well, yeah. So there is that disorder, the misophonia condition, where it creates chemical release, and it changes the chemical in the body, and it gives you these physiological changes. So you can have, like your heart beating faster. So you can have physiological changes, and you have some, psychological components to it.
Yeah, Doc, we're out of time. But we're gonna have to continue the subject next week because there are so many aspects of this that because mental health is. There are so many distractions around us that can lead us down a path because like some people would read something here, they would go on the phone and watch something else, and then they discredit that what they're hearing there. And all of these things can lead down a dangerous path too. So I'm happy that we're having this conversation. To the viewers, thank you so much for joining us tonight. I hope that I know a lot of people are not on here tonight because of the crickets. Tell me what's the score. Somebody send me the score quickly so I know what's going on. But before we close, I just want to say thanks again for joining us wherever you are joining us in the world. We are going to be having somebody's now calling, but we can't take that call now. But next week we're going to continue this conversation. Just to let you know, that Doc will be out. We'll be heading out of the country for Christmas. But we will continue.
We'll arrange something.
Yeah, we're gonna just to let you know. But so continue to send in your questions to us, and we are happy to have you as part of the show. And it's because of you that you make this show possible. So thanks again for joining us tonight. We're gonna talk to you again.
I want to just make one point.
Yes,
just interrupt. I think the greatest therapy for people with all sorts of illnesses, love is very important. And I see people in their worst times in every aspect when they're going through bad patches. I mean, just giving some love is very important. And not when you're down and out, we want to knock you down and out more.
Kick you down further.
We don't want to do that.
Yeah.
So I think that's an important message. In closing, thank you, viewers, for watching. And Akash, thanks again for having me.
Yeah. Again, as I want to reiterate what Doc is saying. If you notice somebody's having a little bit of a, you notice something that's a little off and so on, man, look, it's you can go to them and say, hey, what's going on? Talk to me, I'm all right. You've known me for a while. I'm confidential. Talk to me. Let's meet. Sometimes all they need is that one little conversation to make a difference. Because many of the persons saying here, one person said both two aunts died because of these conditions. The only way you would realize how serious it is when the person's dead and we can't make a difference in their life anymore. They're dead. So again, look out for the people who look out for everyone out there, and when I talk about look out for those who are not looking out for you on the roadways. Too many accidents. Have a wonderful night, everyone. Next week we'll be here again on Tuesday at 8 o'clock. Thank you for joining us and stay healthy.
Lovely. Thank you.